Welcome, everyone. Hello, and thank you for joining us today. Thank you so much for joining us for POCUS Certification Academy for today's POCUS Device webinar. My name is Daria, and I'm the Global Learning Program Manager with the Academy, and I'll be your official webinar host for today. The webinar is now beginning, so all lines have been muted. Please use the Q&A box for any questions or the chat box if you have any comments. The presentations will include PowerPoint slides with our presenters, and then after the presentation, we'll have an official Q&A time with our presenters. And today's topic is ultrasound education and medical education and residency. And our speakers are Dr. Krause and Dr. Dinh. Welcome. Dr. Krause is an internal medicine physician, and Dr. Dinh is an emergency medicine physician who are part of Loma Linda University Medical Center. And they're also co-founders of POCUS One-on-One. POCUS One-on-One is our official POCUS education provider that focuses on teaching POCUS to students, nurses, and physicians. Welcome, Dr. Krause and Dr. Dinh. We're so excited to have you today. Feel free to introduce yourself and we'll get started. Thank you.
All right, thank you, Daria. You can hear us okay?
Yes, all
right.
Good.
Well, thanks for having us here. We're really excited. We've been really looking forward to this presentation because we love point of care ultrasound. And we're just excited to share what we've been doing at Loma Linda, as well as other institutions for the last over 10 years now, trying to integrate this within medical schools and then residencies and so forth. Like Daria said, my name is Vi Dinh. I'm RDMS, RDCS certified as well through the ARDMS, which POCUS.org is affiliated with. I'm a professor of emergency medicine, as well as critical care. And I direct a lot of the ultrasound teaching for our medical school. We started back in 2010 or so. So it's been over a decade since we started it, and we've been through a lot of trial and error as well. And as well as the ultrasound director for our residency and our poem crit department. So I'm going to let Reed introduce himself.
I'm Reed Krause. I am an internal medicine trained hospitalist at Loma Linda, and I'm RDMS certified as well. I do ultrasound directorship for our internal medicine residency, our family medicine residency, and with our medical school, I focus a lot on the clinical integration of our POCUS curriculum.
All right. So just to start things off, we're going to ask a simple question just to gauge our audience here. How important is implementing POCUS education for yourself or your learners?
And
we'll give a few seconds for you guys to answer.
Don't forget to share your slides, just a quick reminder.
Oh.
But the question should be on your screen, so feel free to start answering our first poll. Give me 1 second. You should be able to see this on your screens. Feel free to answer that question. See a lot of participation, so we'll get another 5 seconds. But 60% answered. And we had also a lot of comments. Here you go.
Okay. So it looks like, well, 72% say it's very important. 24% said important, and a few people said, one person said not very important, one person said somewhat important. So I guess the majority of people obviously feel very strongly about POCUS education for yourself or your learners. So we're going to go over 3 basic things, like why POCUS education is important. It seems like everyone here feels like it is. We want to reemphasize why that is and why we feel that is, how you can start implementing it and how we started doing it. We can share with you our experiences over the past decade, as well as what this can look like in the clinical scenario for your learners or yourself. So let's start out with why. So as we know, when computers first came out, right, they were really bulky, they were slow, they're really expensive. And back then, if you didn't know how to use a computer, you can just be just fine. However, now we know like these computers are getting smaller, more compact, more affordable, and they're insanely powerful to handle lots of loads. And if you think about it, I don't know, we have people from the United States, we have people from outside, like across the board though, medicine is transitioning towards electronic medical records. We're doing e-prescribing. So back then, if you didn't know how to use a computer, that would be fine. But this day and age, in order to practice medicine, there's no way you can practice medicine without being computer literate or technology literate. And this is what we're seeing as well throughout the clinical exam. When I started doing ultrasound over like about 15 years ago, it wasn't really implemented back then, point of care ultrasound. But now with technology getting better, and this is my first ultrasound machine that I ever owned. This was donated to me from urgent care. This is over 12 years ago now. And this was 400 plus pounds. And I remember it took like 4 or 5 people. I had to hire like movers just to bring it into my small apartment here. So this is my living room. And my wife was not super happy about having this here, but I learned on this machine, and every day I would just scan myself because this to me was like, at least, no one's using this, but I was able to train myself and use this. But having this at the bedside, it's probably gonna be hard to do, right? But now technology is extended to the point where we can have it in our pockets. It's really small, portable. It's a lot cheaper than it was before. And that really expands the possibility of point of care ultrasound. Back then when I was learning it, it was, people were starting to use it, but it wasn't really integrated as it was now because the technology didn't keep up with what we needed at that time. So what we're seeing now is huge benefits to our learners. And I can tell you, like, Reed was one of my medical students, he was my fellow, but for residency applications, that learners who have point of care ultrasound training and experience, they shine on the residency applications from throughout med school. Learners who had point of care ultrasound training during their medical school experience actually do better in residency as well from our experience, because that's one less thing for them to learn. They're already inundated with a lot of material already, work hours. Like learning point of care ultrasound is just one more thing that they sometimes don't want to do, but if they already have that experience early on, that really helps them during their residency experience themselves, and allows them to do more procedures and so forth. Core competencies. So even though a lot of specialties don't have it as core competencies yet, such as emergency medicine already has as a core competency, but internal medicine's going towards that way. Anesthesia is going towards that way. Family medicine is going towards that way. So a lot of residencies are heading that direction. If they're not, even though they're not fully there yet, we're seeing the trend going towards that direction. And of course, improve patient care. That's what we really strive for, is like, how do we improve patient care by allowing our residents and our medical students and our trainees to have better, clinical and timely care of their patients. And another thing is that we're seeing is that, just a feeling for the learners to not feel like they're left behind, because learners, we see students, residents coming in from different programs who have not had any point of care ultrasound training. And I can tell you for sure, they feel like, I wish I had this training when I was a student. I wish I had it earlier, and so forth. So, and we've published a lot of studies, Dr. Krause and I, over a dozen studies on point of care ultrasound medical education, but we're just highlighting a couple of them. But one of the biggest questions when we started doing this was, hey, is it going to make their physical exam worse? Like, we're ordering CT scans all the time, MRIs. But we found that when we implemented point of care ultrasound within our medical education, it actually improved the physical exam, as well as students here who were trained in ultrasound versus students who were not trained in ultrasound. We saw a very, the students who were trained in ultrasound correlated with emergency medicine residents who were formerly trained in ultrasound. So even as a first-year student, they were able to get their ultrasound skills almost to the power of emergency medicine residents with some simple training, whereas students who were not trained in it had a significantly lower scores. This is just an example of why we're so excited about this. This is apical 4-chamber view of the heart, and there's a clot in transit right here in the right atrium. So this patient was something that a 4th-year student actually diagnosed. When I was in the ICU, there was a crash intubation in one room, and I just had her say, hey, this patient is hypoxic. her blood pressure's not doing too well. Can you just go do a quick scan and tell me what you see while I'm doing this? And she came back and saw this finding. This drastically changed our management. And this wasn't like a POCUS expert. This was just a fourth year student on her rotation, able to find these findings. But imagine waiting for a formal echo a day or two later, and then seeing this, that could have definitely changed. This definitely changed our management in a timely manner. So another thing is that you got to think, having POCUS education, not having it is just unfair to your learners, right? And unfortunately, POCUS education isn't standardized for or available across all programs. More programs are implementing it, and we're going to show you how we did it. So to help anybody who's out there that's trying to implement in their own program. And we're seeing this really help learners' careers. So I think in the best interest of your learners, getting this in as early as possible will really help them. And we've seen that throughout. So the next question we have is, what barriers do you have to integrating POCUS education within your own institution or for yourself? And I think Daria's going to put up the question right now.
We are about at 50% of participants answering the question. So I'll give another 10 seconds.
All right.
Here are the results for you.
Okay. So this is interesting. Okay. So surprisingly, cost is only 11%. Machine availability is only 7%. Quality POCUS education is 7%. Available faculty, 27%. And then all of the above is 49%. So it sounds like most people are having issues across the board. Available faculty seems to be a big one as well. So we're going to go over how to kind of address these barriers or how we did as well. So we're going to go over two main things is obviously ultrasound machines are going to be a big one. So if you don't have machines, it's going to be hard to train your learners. And the next thing is going to be the actual POCUS education and how we were able to use POCUS education to help facilitate learning for our learners. So the first question is, what machines should I buy? This is probably the most common question we get from people emailing us to POCUS 101 is like, what machines should I get? So obviously there's cart-based machines that are big, but they have really good resolution. But we also have these handheld versions as well that are cheaper, more portable, and really easy to use. So the question comes though, like, which machines are the best for educating your learners? Well, unfortunately, it all depends, right? So cart-based machines, like we talked about, are really good for learning the images because the handheld ones, they don't give you the same image resolution as well as some of the options that you do have with the cart-based systems. However, the handhelds are really cheap. They're really easy to distribute. So we're able to use this in our clinical setting for like our third or fourth year medical students or our residents to take around with them on the wards in the clinical setting. So we personally at Loma Linda, when we started, we only had 2 cart-based machines and we were training like 400 students. It was a mess. We had to schedule things. It was really hard to do. But over time, we started adding more cart-based, and now we eventually have 10 to 12 cart-based machines, as well as how many butterflies we have? Like
we have 15 now.
Yeah, so we have like 15 to 20 butterflies that we are able to lend out to our medical students as well. So we think, cart-based is probably best for the preclinical setting where you're really teaching them how to get the anatomy, how to look at things with good resolution. But handhelds are really good for the clinical setting where then when they know how to look for the anatomy already, they can use it in the clinical setting. But if you don't have that budget, handhelds are an easy way to go. If you have like $10,000 budget, then probably go for the handhelds. If you have a bigger budget, I would say having at least one cart-based machine is really good to help the learners as well. So in terms of POCUS education, here's the big part of this presentation. And what we're seeing is there's 2 types of POCUS education. There's an asynchronous, where you have the online learning, kind of flipped classroom type of model. And then there's live teaching. The old model used to be really a lot of live teaching, where we would give didactics, lectures, and then go ahead and scan. However, the newer model, what we're seeing that works best is having asynchronous online learning, where you have the learners learn at home at their own pace, at their own time frame, getting all the ultrasound fundamentals, anatomy, the pathology, main pathology, and all the lecture-based things. We found that the learners, especially this generation of learners, really gravitates towards online learning, and they prefer that over the didactic, like regular didactic learning. However, the live portion that we found that is the most practical is using that time for hands-on practice. And this is also, a lot of people said they had not enough faculty available, where this allows you to really leverage using faculty for what they're meant to be doing, is hands-on practice, right? Instead of just giving didactics and live lectures all the time. So in terms of asynchronous learning, we have one more. This is the last question we have for this talk, but what are important things you look for in an online POCUS curriculum for your learners?
We're at 50%, so another 10 seconds. And here are the results.
All right, so it's another all the above. So costs, being user focused, having a phone or tablet app, having a learning management system, and 56% just said we need all these things. So we went through the same thing, and we had the same kind of things that you guys are looking for as well. So obviously the best thing that you could do is make your own content. Right. So a lot of institutions are doing this, like, let's make our own content, give it to our users, because this is exactly what they want. This is what we want for them. However, I can tell you now that it takes a lot of time, a lot of energy, a lot of money actually to create your own content, and a lot of expertise as well. So if you can, I'd say that's probably the best option if you can really tailor it to your students, right? There are free options as well. There's like YouTube, blogs, Twitter, etc. We actually started our own, this is how we kind of started, for POCUS 101, is we created a blog with very complete tutorials. If you ever want to visit that, feel free to, but it has like complete written tutorials, kind of like a textbook version, right? We also had YouTube videos that we would link back to our students, and it worked out great. Our students were using it and so forth, but there were limitations on how much we could actually use for our learners, because we couldn't assess their knowledge, right? Like giving quizzes and so forth, and seeing how much they were retaining. There's no certificates that we can give them, and it was basically impossible to keep track of our learners using just kind of these free options, as well as a lot of them were not really user focused. A lot of the free options that we saw. So we went ahead and went through a bunch of different online courses that we use for our learners, from our residents to our medical students. And like between Reed and I can tell you, we tried everything out there, and everything was things were good, but they weren't like really didn't hit home. It wasn't really, a lot of them weren't user focused, or the cost was too high, or they didn't have a phone app or things like that our learners really wanted. So we ended up creating our own courses. It's called courses. It's at courses.pocus101.com. And we tried to address all these issues and exactly what our learners would want. So we surveyed thousands of learners and be like, what exactly would you want? How would you want it presented to you? And let's create that versus what I would want, or Dr. Krause would want, or another faculty would want. We really based it off the learners to create this platform. And what we found out from feedback was image acquisition was a big deal. A lot of other resources didn't really focus on that. They just had like a brief presentation on, point this indicator here, and now let's go through pathology, but we really focused on image acquisition because our own learners really thought that was important. Another thing was troubleshooting. So here you see it's a foreshortened left ventricle here, the parietal long axis view. And so we would recreate these bad views and then show them, hey, you rotate counterclockwise to get the parasitial long axis view. So troubleshooting views, we didn't see a lot of resources have, and our learners were always asking like, oh, if I get this, what do I do? So we basically went out and recreated every single bad view out there, and then showed them exactly how to get that view again. And this has been a big thing for our teaching, is that and the learners, as well as faculty that were trying to help teach this, what they thought it was really beneficial, because when their learner had a view that wasn't correct, they knew how to troubleshoot that throughout all the views. So we did this for all the different, cardiac, lung, all the different organ systems as well. So yeah, we really focused on image acquisition here. So you see here, this is for our cardiac course. We have a lot of image acquisition, and then we go to pathology, because we feel like, the learners, the biggest obstacle for our learners was not identifying pathology, because if you saw a pericardial effusion, it's not that hard to see, right? But if they can't acquire the image, it doesn't matter how much pathology they know or all these formulas. If you can't acquire the images, it doesn't matter. So we spent a ton of time on this, and this is what the users actually wanted, and we've implemented this to thousands of users, and they all across the board prefer it this way, and it's been pretty successful. Another thing was simplifying pathology, with good illustrations. Our learners really wanted that, so we created good illustrations for them to redemonstrate and easily learn pathology that they need to know in a point of care setting, as well as assessing knowledge through quiz-based, case-based scenarios to help them reinforce all that learning into more of a clinical setting, and then finalizing their quizzes, and then certificates too. This was a big deal that our institution wanted, was how do we show that they actually completed something, and we can send out to the students or faculty to show that they've completed it in a proper way. And all of our courses are verified through CME. As well as being accessible anywhere. This was a big deal for our learners, and being able to access it as a POCUS app on your phone at the bedside, where, hey, you might have forgotten how to do parasitial long axis view. They can just look up that video right away. Or if they want to look up, what's a pericardial effusion, what's the definition of tamponade, they can look up a 5-minute video on there as well. And the learning management system is a big deal for a lot of our institution, as well as other places, where you can keep track of your learners. You can see exactly, who's completed what, download Excel sheets for them, add and delete users easily. That was a big part of a POCUS online education course that we were looking for. So we created that, as well as making sure it was high quality. That's why we approached POCUS.org, and they looked through our curriculum as well, and we're a POCUS education provider. So we wanted to make sure that it wasn't us thinking that the educational quality was good, but also external resources, validated resources as well. So another thing it always comes down to is cost, right? We went through a lot of different programs, and it was crazy, the variation between costs and quality. So in terms of costs, we wanted to make sure that when we had the courses that was accessible to any institution, to make sure that cost was one less barrier that you would have to overcome, in order to get your students or your residents good training. So we had group rates for trainees for like just $30 per student, or $50 for residents and fellows, as long as you have greater than or equal to 30 learners. So we thought this was a good, rate based off of what we've had to overcome with our budgets in the past. And we've, like I said, we've have been able to implement this in thousands of trainees so far. So just to recap, for POCUS education, the asynchronous learning, the online curriculum, really helped us bring together a lot of the ultrasound training for us, and allows us to do live hands-on scanning between the learners, the faculties, as well as the patients in the clinical setting. I'm going to hand it over to Dr. Krause, and he can show you kind of how we use this throughout in a more of a clinical setting, and how he's been able to implement it.
Thank you. This is the most rewarding part of my job, and that is working with third year, fourth year medical students, family medicine residents, internal medicine residents, and many other residents from other specialties who come scan with us, teaching them to apply their POCUS skills at the bedside. When I was a medical student, I was one of only a few students who really embraced POCUS as part of my routine patient care. Even though I was highly motivated, I felt the pain of not really having that routine access to handheld devices or cart-based ultrasound machines. And most of my learning resources, like Dr. Dinh said, were mainly like blogs, YouTube videos, and it was really difficult to quickly review that content right before scanning my patient at the bedside to regain that confidence that I know what I'm doing with this exam. And these barriers really prevented a lot of my classmates from actually scanning patients. So we had a lot of didactics, but it unfortunately wasn't getting utilized at the bedside. Nowadays, we have had a lot of advancements. Many of our medical students, and there's a resident right here that we have pictured, can access, many of them have access to handheld ultrasound devices, and they can self-learn at home as they prepare for an ultrasound session. They can ultrasound themselves while they watch our short videos, which is a lot more engaging if, as you watch the video, you then like, oh, I can do that. And then they do it at the same time. So they're a lot more engaged. They can not only ultrasound themselves, but then they can ultrasound their family or housemates. And even in some unique opportunities, some of our students even practice their OB ultrasound at home. And now with more access to ultrasound machines and these just-in-time learning resources, every year we're seeing more and more students and residents are embracing POCUS as a crucial part of their education. Probably the exam I use, more than any other on a daily basis when I'm on the wards is that of the fluid stats exam. So one of our key ideas is we want to empower our learners to use ultrasound for the most common clinical questions that they encounter, so that they have frequent opportunities to utilize it and learn it. Because in the past we had spent a lot of time with our faculty giving didactics and not much time with them scanning with our learners with patients, many students just never developed that comfort of ultrasounding their patients on their own. For our internal medicine residents and clerkship, we do these fluid stats rounds. We use both handheld and cart-based ultrasound machines, and we ultrasound lungs, heart, IVC, and it is amazing to see how shocked they are, how quickly they can identify pathology at the bedside. They get really excited to see their first dilated IVC on a heart failure patient. And it is so much more powerful to see a severely reduced ejection fraction on a heart failure patient when they have already seen several normal hearts. Once a learner knows a POCUS exam from doing live scanning sessions and watching our short videos, they can quickly review the videos right before they go to the bedside or look at the blog through the app. And then they go to perform the exam with a much higher confidence level because they are able to just review it in a minute or two. Once our learners are starting to apply their POCUS in their routine practice, they're often surprised how much time they save because they're able to answer their clinical question quite quickly with POCUS. I had one resident who, the day after our fluid stats exam, had a patient that the nursing had called them and said, our patient had a bladder volume of over a liter, and this patient had an AKI, and they're suspecting urinary retention. And the nurse said that they had tried straight cathing multiple times without much success. So the resident brought the ultrasound to the bedside and quickly refreshed their knowledge on bladder ultrasound with our app. And within a minute, they could find that it wasn't urinary retention. There's actually ascites there, that the nursing bladder scanner was confusing for volume in the bladder. So they were able to adequately and very quickly change course in how they're approaching this clinical problem. Another question that I have come up on a very frequent basis is, what do I do with these incidental findings with our learners? And we found that it's very important to address this because learners want to know what to do with their findings. For example, I had a resident who found this left ventricle apical thrombus on a patient that presented with COVID pneumonia and shortness of breath. And then we found had TIA symptoms recently from a recent admission. We put them on a heparin drip and ordered a formal ultrasound. And on this instance, the formal ultrasound actually only showed apical fibrin strand, but did not see any clot or mass-like structure. And this was done only a few hours after we had done our bedside ultrasound. So how do we address this when we have something that is seen on our POCUS exam, but not on the formal? And this is where our radiology colleagues, our cardiology colleagues come in handy, because they are often some of our best teachers and our best resources for these kinds of instances. So it was very important that we brought these images to our cardiologists, and they actually amended the TTE report, saying that it was seen on POCUS exam and that patient was put back on their heparin drip for proper treatment. So ultimately, unless our learners are using POCUS with their patients, then their POCUS skills won't really progress. We found the key to getting our learners to use POCUS was instead, we found that the key to getting our learners to use POCUS was to get our faculty time and giving them hands-on training instead in didactics. Our goal was to really empower our learners to use POCUS to help answer some of the most common clinical questions of each clerkship. For example, in surgery, we do, in OB-GYN, we do the maximum vertical pocket, fetal heart rate, and fetal position. In our surgery clerkship, we teach them the EFAST exam. In family medicine, they learn the AAA screening, DVT, and thyroid ultrasound. Internal medicine, they learn their fluid status exam. And then in their fourth year and residency, it's very rotation and specialty specific. The important thing is to really empower the learners to integrate it into their routine physical exam. Answer those quick clinical questions that they are going to very frequently encounter. It's more efficient and effective to have the same learning materials for your students, residents, and attendings as well. Having that one basic curriculum for all your POCUS learners will save your faculty time for hands-on training instead of doing long didactics. Because the true benefit of the POCUS education is when your learners are actually using it to improve patient care.
Yeah, so we just wanted to recap. We created POCUS 101 because we felt like there was a big gap for our learners, a consistent gap. But we feel strongly that it doesn't matter what you use, you need some type of asynchronous learning, especially when you have a low amount of faculty. Like, it's just Reed and I, we're training like literally thousands of people at one institution. We have 800 medical students. He has like 50 residents in his IM program. I have 50 residents in my emergency program. We have Palm Crit fellows. We're training family medicine residents too. So having like two people, it's impossible to give lectures all the time. And that's what we were asked to do in the beginning, like 10 years, that's what we were doing. Like, and my wife hated me, and we're like, why are you giving lectures like all the time? Which is great. Like, giving lectures is great. But in terms of like feasibility and resource wise, it it just wasn't happening especially when you start extrapolating to more and more different types of learners. So having a good online curriculum, and then so that's why we created POCUS One. But use whatever you can, whatever works for you. But this, having asynchronous learning helps you utilize the ultrasound machines more, because now, as we were seeing, it's not about having access to machines like it was 10 years ago. That was a limiting factor. We didn't have machines, but now they have machines. They just don't know how to use it. There's no good education for it. So for example, our family medicine residents, where everyone has a butterfly, but they weren't using it at all because they weren't educated on how to use it or had a good resource for that. And this eventually applies to our learners, getting a better learning experience where they can access information anywhere and whenever they need to. Faculty development, we found that this helps a lot. We just trained a group of like 20 internal medicine faculty using the same system that we use for our residents and our med students. Because what we found is, even though you're faculty, doesn't mean you know more POCUS than a fourth year med student who's been through it for 4 years, right? So we found that using this resource with faculty works. And eventually for patient care, we found that, having something that the students, residents, or faculty, fellows can use at the bedside really helps patient care, because then they can review it really quickly, or there might be like this just-in-time learning that Dr. Krause was talking about. So we didn't want to spend too much time. We wanted to make sure we had time for questions. You can always email myself or Reed support@pocus101.com. You can follow us on Twitter, Facebook, Instagram. They're all at POCUS101 as the handle. But we'll take any questions that have come up. Daria.
Yes, thank you so much. This was great. A lot of great tips. And we did have a lot of questions and comments, so I'll just go by one. The first one, how do you keep track of the handheld devices? They seem so easy to be misplaced or get lost in a clinical setting. So.
Great question. I'm going to let Reed handle that. He's the butterfly man at our place.
Yes. So we have... for our family medicine residency, they have one for each resident through a grant. But so that one's easy because they have to take care of their own. For our medical students, we have them a couple of checkout systems. We have some dedicated specifically for a certain clerkship. So they have to check it out at certain times at the beginning and end of the clerkship. And then we have another pool of butterflies that students can check out at any time. I think the important thing is just have a consistent system where someone is responsible for having them sign a checkout sheet and before they hand it to them, and have a specific time when they're going to return it. That's what we found to be the most efficient use of it, so that they're getting utilized, but also that we can keep track of where they are at all times.
Yes, and having a central location to have them all is essential as well. And one thing about the handhelds that we're finding is the charging is another issue, right? Because there's you can't just plug it in and charge it right away. It's like some of them have, like QI chargers or whatever to charge. And so having it always charged and available for students is a big deal for us. So what's the next question?
Yes, thank you. The next question is, how do you keep track of asynchronous learning? Veronica said, I assign monthly topics based on SONASYM, but I have difficulty keeping residents to complete the task. And she was thinking of having a checkoff prior to adding a hands-on session, didactics. Any other thoughts that you can share?
Yeah, so what we've been doing is actually, what we use is, so on our online app, on the phone app, they can actually, it pops up with a certificate. So what we're finding with exactly what you're going on with you is that the students will, if you tell them to complete it by 5 p.m., they complete it like at 4:50. So when you go to your learning management system, like at 4:30, like only half the people have completed it, right? So it's good for like afterwards to make sure they completed it, print out Excels, which you can do. But we have them, this actually pops up on their phone and email right after they finish a course. And then they can just show this to that instructor right before they come into to scan. So that's how we keep track of asynchronous learning. That's what we found has worked the best. Reed, any comments on that?
Yeah, for each of my hands-on sessions and scanning in the hospital. To begin, they have to show me on their app on their phone that they have completed that module that prepares them for the learning session.
Yeah, and
So,
we actually have them step out if they don't, because that's not fair to the other students. Because once they've gone through this, they go in and scan right away. And we've seen like fourth year students, they're like, "Did these guys scan before?" Like, no, they just went through the app, and they're like, "Oh my gosh!" Like they already know all the fundamentals, which is really good.
Yeah, and immediately the quality of their preparedness increased as soon as we started implementing that policy.
Great, thank you so much. We had another comment talking about asynchronous education. Like, how do you maybe lead into the live scanning hands-on session after they complete, didactics online? Do you have any suggestions on how to make sure they, transition to the live scanning and hands-on experience?
So we made, we're kind of biased because we developed POCUS on one exactly for this exact thing that you're talking about. What we found is that a lot of times you have to lead in, you'd be like, introduce this. But when we made the videos, we made it so that literally this is how you position the patient. This is how to where the machine goes, where your body goes, everything. And troubleshooting, this is the person. So when they come in, they are actually ready to scan. Like I just hand them the probe and be like, okay, let's do a personal. Do you have any questions? Let's start there. And then I'll help them troubleshoot. But the biggest thing for us is that we don't have that much time. Like when you're training hundreds of students, you don't have time to like reorient the exam each time. So it's nice when they come in and they already know what to do and start scanning. And we've been able to do like cardiac sessions within like 30 minutes to get through all 4 views for groups of like 5 or 6 learners. Whereas before we'd have to take 45 minutes or even an hour because they didn't know anything coming in. So it gives them time to absorb. But we found with the asynchronous learning is that they learn this stuff and it absorbs and they think about it. And when they come in there, instead of like 50, there's no way they can absorb everything in 15 minutes or that you showed them if they didn't go through this stuff. But if they had this session beforehand, they come in, they're actually a lot more ready than if, without that from what we've seen.
Thank you. This is kind of a flipped classroom, probably thought that you can incorporate. Thank you. Another question is, do you use live patients or mannequins to train or task trainers or both?
We use mainly live patients well, Reed does a lot of the clinical stuff. So we actually have them come in the clinical setting on like real patients with real pathology. I work in the ICU, so they come in with me in the ICU or the emergency department, and we actually scan live patients there. That's after they've already had their preclinical sessions. But in the preclinicals, they scan themselves and they learn on each other, or they're at home scanning themselves with the butterflies or any handheld devices that they have. And we do have mannequins too, but honestly, we have not found, this is just our personal experience. We have not found that, and we've used this like extensively, like 2 or 3 years where we had simulators, we've had mannequins, we've had like blue phantoms, like all that stuff. We use everything that you can think of. And we found that it doesn't take the place of actual, like a real person scanning a real person, no matter how good the simulator is. We just haven't found it to be as effective, and it costs a lot, and it just doesn't work from what we've done. And we tried this out in the very beginning, 2011, 2012, for like 3 or 4 years. And we got the feedback from our learners that the live scanning is the most helpful.
Great, thank you. Another question is there one handheld device you recommend over another?
Well, for me, the most important thing is that it's used. So whatever device will be used and fits your needs is going to be it's going to be the best. For me as internal medicine and for our family medicine residents, we just want one device that everyone used. So it's just much more efficient. So you don't have to train many people on many different devices. We personally use Butterfly because it's kind of like, the 3 probes in one, but and it just simplifies things. But there's many other great devices, and just whichever ones that will be used, I think is fine.
Yeah, and I think that, like I said, the battery issue has been an issue for us, because one thing is that if your battery loses charge, like for a Butterfly, you can't like quickly replace the battery, versus like a Wave, there's a detachable battery, which is nice, but you have to have different probes. So there's pros and cons to each one, the cost. as well. Some of them are subscription based, some of them are not. You buy at one time. Some of them have better image quality, but we ended up with the Butterfly for us because of the cost was there, as well as one probe for everything made it a lot more simple for us, and that's what we found. What we decided on as an institution, as a school, for us, that works the best.
Great, thank you so much. We had a couple of comments on how to implement this type of training at their own med schools, and like what would you recommend, or who do they approach to present their interest in incorporating this kind of training into their where to start sort of thing?
So can you rephrase the question again, Daria? Is it like who did they need to talk to?
Who would they approach to start this type of training?
Got it. I think it's got to be the deans at the end of the day. Like, they're the ones that approve things. But what we found works the best is that we have an ultrasound interest group that we form. And we probably have one of the biggest in the nation, I would say. Like, we have probably like 400 or 500 students that are part of the ultrasound interest group, and we do peer-to-peer teaching, and they use the POCUS 101 app and resources to help teach each other, also to help us offload our plate and they learn a lot too, and the students love it. But what we found is when we made an ultrasound interest group, we, instead of us presenting to the dean saying, hey, I need this for our students, we have the students come up and say, like, we need these for ourselves. Like, this is weird. This is unfair to us that another school has it and we don't. And the cost now, like I said, is getting less. And that's what we're trying to do with our courses, is that really to try to make this one less barrier, because we see a lot of institutions going through the same thing, and they don't want to spend $200,000-300,000 plus in order to get point of care ultrasound education, but whereas you can just use that money for machines like handhelds or whatever to get that started, faculty development, things like that. But it really starts from the students. And if you can convince the students, which they don't need convincing, because they all, students are progressive, they know they need it, and having them come with you to the deans, let's have a meeting with the dean, let's have a meeting with some first, second, third year, fourth year students, and show them that they this is what they want, this is what they need, has been for us very helpful when we are trying to apply for anything or ask for budget and requests and so forth.
Yes, and in addition to this, if you're ready and at that point that you need some help, POCUS Certification Academy can also do a consultation and help you, because we have helped several programs to incorporate POCUS education and certification. And just as a reminder, I saw a couple of comments about certification and credentialing. POCUS Certification Academy is a part of the umbrella organization that is called Intelios, and we are a sister council to ARDMS and APCA, and our assessment is as rigorous as theirs. And we do certification in the POCUS specific areas. So if you are interested in more about how to get certified or how to incorporate certification as part of your programs, feel free to reach out to us and we'll guide you through the steps. We have, as I said, helped several programs to do so. And
of course, you guys can always contact us if you have any specific questions about how we implemented it within our institution, or if there's any way we can help, just feel free to reach out to us. Nothing to do with like the courses or anything like that, but we're more than happy to share our experiences of how we got started. And if we can help in any way, just let us know as well.
Wonderful. I think we have a lot of comments and just thanking you about the presentation. But if you guys have more questions, feel free to email us. This webinar was recorded and will be available within a week. We'll send you a link with the details on how to access the recording so you can share with your colleagues. And again, thank you so much for joining us. I have one last poll for you, and we just wanted to see if you will be able to apply what you learned today. And if you can take a little bit of time and answer this question, this will definitely help us to plan future webinars. And again, I'm thank you so much, Dr. Dinh and Dr. Krause. It's been such a pleasure having you. And we'll hope to see you soon for the next webinar.
Okay. Yeah. Oh, and we got a question from Rachel here. I see that this says the website says $250 a resident, but our slide said 50. Yeah, you just have to email us. And yeah, it's not really available as through the website. You just have to email us, and then we'll work with you. We'll do a demo with you, Dr. Krause and I, and then we can show you exactly if it works for your program or not, and then we can do that discount for you. But yeah, just email us, and then we can get that. I know the website says we made a significant, once again, discount to make sure that it's available to anyone.
Great, thank you so much. But again, if you have any more additional questions, feel free to email us and we'll connect you with our speakers, and hopefully see you next time in our next webinar, which will be next week. Will be about DVT. So we'll see you soon. Thank you so much.
All right. Thank you, guys. Thank you.
Thank you.